like to welcome you to the next MAT Practitioner Spotlight. And today we have a combination, a duo, a team, Mark and Anne-Marie Trombold, who are physical therapists from Seattle or outside of Seattle, and that have been through the program, from day one. Before I even started the internship classes, I taught a class up in where was that? Bellingham,
Washington.
Yeah, Bellingham, Washington, and it just introducing the principles of MAT. I can't say that I really even had the process laid out at the time, and so I was introducing the principles, and Mark and Anne-Marie were at this course, and we developed a friendship, had dinners together, and then they eventually ended up, when I started teaching the internship, they've been around since before I even knew there was going to be a full-blown education program. And so they came through the second internship that I taught, and they graduated. I guess we're looking at 2001, might have been the end of that second internship. They've been through all the master level classes, and then they were in the first RX class that I taught. And like I said, a bond that started before I even started the organized education program. So I'd like to welcome both Mark and Anne-Marie Trombold, like I said, physical therapists that have implemented the MAT processes into their physical therapy practice. And so thank you for being here. Taking the time. It's great to see you both. And so maybe that's the first thing to start with is, you've known me since the beginning. You've seen the evolution, how it's evolved from before I even started teaching the specialist program to where it is now, all the way through the RX, and then some of the things that keep evolving. And what has it done for the two of you relative to your physical therapy practice that you're now retiring from?
Yeah, right.
Yeah.
Well, the MAT process, I know that when I took that very first course from you in Bellingham, it just hit home that, wow, there is something incredibly powerful here. And I remember thinking back to, having these two ACL patients, and both of them from the same doctor, pretty close in, how far out they were from surgery, and both very compliant, and one just progressing beautifully and the other one almost spiraling out of control. And it's like, what is going on here? And when I met you and started really understanding the whole concept of inhibition and increasing loads on an inhibited body, the stress that caused, it's like, wow, that just absolutely made sense of why this happens. And so that was just a huge change in how I started looking at the body. And as you said, we've been at this from the beginning, and even from the beginning with our meager skills, patients would be just blown away by the power of it. So I can't even imagine what it's like now with what you've come up with. If it was that powerful back then, and we've seen it, through a 20-year process, it's such a gift that it's been a gift to us, and the gift that we've been able to pass on to our patients. So powerful stuff.
Yeah, for me, I think I was ready, as you know. I was thinking of getting out of physical therapy and thinking about medical school or some other options, because I just felt like with my toolbox, it wasn't happening. I was just kind of bored. And I had an elite ultimate Frisbee player that went to your Bellingham, not you, but I saw the guy in Bellingham, because I wasn't fixing it with our traditional modalities back then. And he came back like 6 months later. He goes, man, I went to this crazy thing up there, and the guy got me on a treadmill. He did this rubby dub thing, and I got off my knee. There was no pain. And so I went, nah. And so Anne-Marie and I, and Anna was a PT at the clinic, signed up for this when you showed up. And I think for me, it kind of rejuvenated my need or my desire to go into physical therapy, because the paradigm shifted to, wow, the muscular system, there's this huge horizon and the potential to do things outside the surgical framework and modality ultrasounds and electric stim, which were really big back, in those days.
I wouldn't know how to use one.
People were beginning to think outside the box, Gary Gray, and for sure you were seeing lots of, but this was a whole shift for me. And it's like, oh man, you can really play Sherlock Holmes here and figure things out. So that was, it's changed physical therapy for us. And that was 24 years ago, we started doing a private practice, right?
Mhm.
And it's just made our practice.
I wouldn't know how to treat a patient
Yeah, it's been
without
huge.
MAT.
Yeah.
I mean,
Yeah.
if they took that away from me, I'd be going, huh, what do I
Yeah.
do now?
You go like this with the
No
reflex
idea.
hammer, I'd be doing.
Yeah.
Anyway, it's
Well,
been great.
Yeah, and that's great. And I think Anne-Marie, you kind of put a perfect, like the example of two ACL patients. One's doing great and the other is not. I mean, going actually, like you said, on a downward spiral, not moving in the right direction. And that's what I used to see. I mean, I was before I developed MAT, I was the biomechanics specialist in this physical therapy group, and through a guy, Richard Jackson, and Bud Ferrante, who taught courses across the country on pelvic girdle mobilizations and looking at the structure, low back mobilizations or spinal mobilization. And so I learned from that side of it originally, but when I worked as the exercise specialist and I was working on the post-surgical, the ACL repairs, I walked over to the wall and I grabbed the sheet of paper that was all protocol based. From week 1 through 2, 1 and 2, you do this, 2 to 4, you do this, month 1 to 2. I mean, everything was protocol based. And the idea is that everybody needed the same type of treatment. And then, like you explained, one person's doing great with the normal process and another person isn't. And then what do you do with those people that don't do well? And that kind of comes to my experience with my back pain and learning from some of the top specialists out there. Is everything was focused on this muscle tightness and you need to stretch and the reason you have pain. I understood the interrelationships of joints through the people like Gary Gray and Richard Jackson and biomechanics of movement, but the idea that the reason you have this pain is because you're tight. And then to find out actually this tightness, focusing on the tightness didn't work for me. And so I was that ACL client going down the downward spiral, and literally, I've said it, 25 years old, saying, what am I going to be like when I'm 50 with knee pain and plantar fasciitis and SI joint dysfunction? Why is the conventional thought process not working? And that's, I think the best thing to say about MAT is it's an adjunct to what you do. Like it's not competition. I mean, you, as physical therapists, you were able to take the principles and tie it into your physical therapy practice and have success with it. And I think that's one of the main messages that we want people to know. We're not trying to compete with any modality. I mean, if you can get muscles jump started and tighten, improve the connections between the nervous system and the muscle system, I mean, then all the corrective exercises and reinforcement work and functional movement, you get better results from all of it. So it kind of prepares your body to tolerate the forces that come with both exercise and rehab.
Absolutely.
Yeah.
I mean, that was one of the things that was so great is that people come in with different modalities that they're using, and let's just test our theory. We'll go show me what exercise you're doing, and let's test it before and after and see what's happening. And it kind of gives you, it's the best diagnostic musculoskeletal tool, I think, in physical therapy that I've ever experienced, that you can really see what you're doing and test your the effectiveness of it.
Yeah, and I think one of the keys, I say is, how do you know? How do you know when you put a force on somebody's body, whether it has a positive or a negative effect? And so if it's having a positive effect, you have this ACL patient that's doing great and I mean, progressing well and going with the program. But if it's having a negative effect and you don't identify it, then those are the ones that start going down the downward spiral. And I love that you said that it's the diagnostics is, I don't care. I don't have an opinion against stretching or deep tissue massage or foam rolling or anything like that. But I know anytime that I would stretch or get deep tissue massage when I was younger, I couldn't get out of bed the next day because I'd have numbness and sciatica down into my big toe. And I'm sitting there like, what's wrong with me? All of this makes sense. I need to have mobility and all of it made sense, but it didn't work for me. And then the how do you know says, hey, you could stretch the hamstrings and it could expose a vulnerability and weakness in the hip flexors that the hamstrings are tightening up to protect from. And or you could say, I stretch the hamstrings and the hip flexors remain strong and everything's stable and strong. So we had a positive effect out of this treatment. And so the diagnostics that you mentioned, Mark, are to say, it's not opinion anymore. It brings objectivity to our subjective evaluations to say, hey, you need to stretch because that's going to help increase your range of motion. Well, if you have mobility,
I've even gotten bolder at the end of my career and saying, you know what, they'd say, well, I'm really into doing a certain modality. And I go, let's test it. And if I really felt like it wasn't working and it was actually contraindicated, I would actually just say, you know, maybe let's not do that for a while because it's not affecting you the way it should. And you can at least just point that out. You don't have to actually just say,
exactly. It's not, but the nice part, like you said, is you can show them. It's not an opinion. It's like you just did that, put that stress on your body, you stretched your hamstrings or whatever, and it brought out these weaknesses. And we know whenever you come in with weaknesses, you're in pain. And so what you're doing to try and help yourself on your own is creating these weaknesses. So let's back off of those until we get your body in a better position so you can tolerate it. And then if you prove you can tolerate it, then you can stretch every day if you want to. But it's, again, like you said, it's diagnostic. It gives you information that a lot of modalities, well, it's your piriformis or it's your psoas. And we have generalizations, or again, with the protocol-based thought process, we think that what we do, if posture's bad and you have protracted scapula, we need to strengthen these muscles and stretch the anterior muscles. And it's like, well, how do you even know if that works? And then they come back 6 weeks later and they still have there's forward shoulder posture and kyphotic position. And it's like, well, all those corrective exercises may have been, at best, they really haven't made a change. At worst, they may have a negative effect rather than a positive effect. Yeah. And again, how do you know?
I had a really good example of that whole thing of testing the body, because I had a prima ballerina. And, you know, of course, their warm-up is all about, there's a lot of passive stretching in there. And, you know, we were talking about stretching, you know, active and passive. And I said, you know, this is a part of your warm-up routine. So let's do it and then test you. And you could stretch her passively till the cows come home, and she stayed solid. Yes. And then I had a patient who, very athletic, she was a foam roll instructor. And so, you know, each time she'd come in and there was inhibition, and I said, you know what, I wonder if this may be a component of the inhibition. And so gave her a foam roll. I said, let's just test everything before, got everything strong, and then had her foam roll, and everything was shut down. And she just looked at me and she goes, what do I do with this? I teach this. Right. Bad, I'm not sure, but for you, this isn't good. So it was so nice to be able to not just have an opinion, but be able to test each of them. And it was very clear to them and to me that, you know, with the ballerina, yeah, you're good to go. And then with the foam roll instructor going, yeah, maybe not so good for you, but it's testable.
The other thing, just on this note, is the specificity of the diagnostic component of MAT. For example, if I get a prescription from a doctor that says adductor strain, well, that's a very common script that would come in from a doctor, and being able to actually go through and look, well, is it really an adductor or is it a medial hamstring? I mean, you know, so having that tool bag to kind of like, and not necessarily argue, but I would just write back in my note to the doctor, I also think that, you know, semitendinosis is an issue here and we're addressing that. And they always really appreciate that because they acknowledge, hey, you know, musculoskeletal, it's kind of in my tool bag, but it's not as nearly as specific. So you get all these people coming in from doctors that really want to have more specificity in the diagnostics, which has been awesome with MAT.
Yeah, and let's go with that, because I know in our conversations previously, what has it done for you, like over the years, like over 20 years, and your relationships in the medical field with the physicians? Because I'm not a medical provider. My degree's in exercise with an emphasis in exercise science, and I don't have the license to diagnose or treat injuries. And so I look at everything from a neuromuscular standpoint. I don't bill insurance. I don't use insurance codes, and everything's on a cash business or basis. Well, you're in that insurance, I mean, controlled realm. Medical providers are saying, like you said, adductor strain, or insurance is saying, well, you're supposed to be treating their knee. Why are you treating them, doing things in their core? How has it worked for you in a physical therapy practice? And what's been the response by the medical providers from a referral-based standpoint?
Go ahead.
It was very interesting in the beginning when nobody knew about MAT. Patients were getting better, and I started getting doctors coming in as patients. And as soon as they became a patient, they were absolute believers. And then they just sent everyone, all of their patients, especially their really challenging patients. And they no longer would write a script of, adductor strain, they would just give, just treat, evaluate and treat. And so there was a lot of, it was really nice then also because the communication back and forth between the doctor was so much easier because we were on the same page. And then, so there was that whole group of doctors that also became friends, because we had so much interaction. And then there was another group of doctors who just heard through the grapevine, I was kind of seen as the SI specialist. I saw a lot of women my age, a lot of pelvic pain, SI dysfunction, hips. And so, and whenever they had a patient like that, they'd just say, well, I don't know what she does. Just go see her. So it opened up so many doors. There was one doctor, it's kind of funny because he was a hip surgeon, and I finally ended up going to see him myself, and he's going, oh yes, you're the one that took all my patients away. So it was, I mean, it really helped to open the door.
I remember one time we went in to meet a doctor. I won't say his name, but he was a big time epidural injection guy at doing injections. And he had us come in, and he had his patient up on the injection in the room, right, to do the injection. And he goes, hey, just treat this guy right there.
Mark's like, no,
like,
we had just been through your class.
And he goes, what would you do that's going to keep me from injecting him?
Don't do it. I'm like,
I wasn't sure you should do that. So she starts treating the guy right there on the table it's not an operating, an OR. It's like an OR, right? And I'm like, this is a long time ago. And he gets up and he moves around. I'm not kidding. I'm just going to sound hokey, but he actually I don't think I want the shot.
He goes, Doc, you know what? I'm going with them. I'm out of here.
And he showed up a week later with all this food at the clinic, and he became a patient. So I think the thing is that once we started seeing the doctors, and I think the cool thing about the doctors, they realize what they don't know. Their specialty, all my spine surgeon guys, man, I wouldn't want to do their job for anything, but they're really good with the toolbox in the back, putting the pedicle screws in and doing all that.
Right.
But when it comes to testing them, it's like testing patients. They just kind of went, like she said, just go in there. And if it doesn't work, I'm here.
Yeah.
Right.
Yeah.
Which I really appreciated. They didn't send a script saying do an ultrasound and massage. They just would let you do it. And I think that was the beginning for us years ago, is that you just develop, like they have this tool with MAT that I don't understand it, but it works. And they were very good with that. And that became a kind of a place for us to start. And actually our whole practice is built on that.
Yeah. That's great. And then it's funny because, so shoot, in the 80s, late 80s and early 90s, after I was a strength and conditioning coach at Fresno State, and I was now the guy, the exercise guy that was dealing with injuries, where I was the functional movement range of motion specialist. I hadn't even put together MAT at the point, but I had worked at that Richard Frontan Jackson physical therapy and understood biomechanics and kind of put my own process together. It wasn't even MAT yet. the team doctors at Fresno State, I mean, that I had known for years, Dr. Rod Kraft and Eric Hansen. Eric Hansen was the orthopedic surgeon. Rod Kraft was the general practitioner, and they were the guys. They were the ones that went in on doc night on every Wednesday night in the training room, evaluated all the athletes. Well, they brought me into their clinic and had me work out of their clinic. They hired me, and basically on the prescription, they billed it through. It was when insurance, you could do things with insurance, and they would bill it through their insurance. But on the prescription, it would say rule out biomechanics as the cause for this injury. And so if they were going, they didn't have time, they were already busy. So surgery was the last resort. And so literally their whole idea was if it doesn't help them, then we'll do the surgery. But if it can help them and prevent surgery, then they won't go under the knife. Yeah. And I think back of that, boy, they were so far, ahead of the game in the idea of how to intermix and avoid surgery, and like literally rule out biomechanics as a cause of this knee injury or patellofemoral syndrome, whatever it was. And if I couldn't help them, they'd do the surgery. If I did help them, then it was one less surgery they had to do. And I thought they were beyond their years when they did that. And that was in the, like I said, the late 80s and early 90s. And that wasn't even MAT. It was just my understanding of the interrelationships of joints and biomechanics and foot's relationship to the rest of the body. So as physical therapists, like you're talking, it's the pain can be far away from where the dysfunction is, and having that freedom with the doctors that prescribe to you, just say, treat them. Find out what's wrong, find out what you see, and work with them to have that trust. That's awesome, because
you should feel really good about the fact that if we can divert people from having, for example, I saw a lot of pre-spinal and post-spinal surgeries, and that's just a big slippery slope. The success rate on spinal surgeries and fusions is not great. It's really low. And having a sister that's on her 8th or 9th one, I would just say if she's, but the point is that being able to keep so many people out of surgery and give them a chance, there's no downside. I tell patients, look, if you do this and you have to have surgery, your post-op work will be so much less, because you've already gone after the inhibited system. You already understand the core, what to do, and we'll be able to buzz through it. And there's a high chance, just because you have a spondy doesn't mean you have to go in and put pedicle screws in it. Huge number that never had to have the surgery, and that's just because of MAT. So that's been awesome.
That's great.
So
that's probably the thing too, is what you said, it is that even if it doesn't resolve the issue, if it's degenerative and you need to have the surgery performed, they go into the surgery stronger. Most people that go into surgery are at wit's end. They've been in chronic pain forever. The integrity of their neuromuscular system is so low that they're going into surgery so weak that they come out of it weak. And then you got a much bigger job to get them through their rehab to get them healthy again. But if you go through the process, if they get MAT prior, I've had clients that have ended up having surgery, and it's like, this doesn't answer everything, but if they have to have surgery, they go into it so much stronger, and they come out, and like you said, the rehabilitation process is so quick because they're coming out of the surgery stronger. They already have an awareness. They already have muscles activated that wouldn't have been activated, and now you just kind of continue where you were before the surgery, and you don't have the years of compensation and adaptation that leads them to the surgery, because you actually make them stronger going into surgery.
And I had you got to see them, and you took notes on kind of what you were seeing, and then when they came back in, I kind of had a schematic of where to start.
Right.
I could come in and test what it was. If they had an ACL, their hamstrings were really great before, and then I kind of know what I want to look at. So that's a great way to implement it into the conventional therapy process.
And I can speak personally to that, because when I was 35, they told me that I needed bilateral total hips. And at age 60, I finally, there were too many things that I couldn't do. And I finally decided, okay, it's time. And because of, well, MAT kept me going for what's that, 25
Yeah.
plus years,
Mhm.
you know, and staying so functional, like, so that I didn't have to have a total hip back then. But when I finally did it, I mean, I'm like a year out and I'm mountain biking, crashing my
Kiteboarding.
mountain biking. Yeah, kiteboarding,
Yeah.
skiing. And I mean, I just feel like I
Yeah.
breezed,
Yeah.
absolutely
Yeah.
breezed through. I think I
Yeah, you're kind of a
one day.
poster child for that. So.
Yeah. So, but it has so much to do with, you know, having the strength going into it,
Mhm.
really never having a down day, and then knowing what to do coming out of it. And
Right.
what's so interesting is all of the, you know, all of the precautions that they say, you know, that you have to follow. I'm like, wow, that's totally opposite of what I know my body needs. You
Right.
know, it's like, don't work the adductors. It's like, I need that adductor stability. So, I mean, I'd be working on myself too, the best I could.
Don't try this at home.
Don't
though.
try this. And I said that. I said to Mark, he's going like, God, you're doing so great. And I go, I know, but I don't know
Yeah.
if I could do that to my patients because it's so against the protocol.
The
So
liability. Yeah.
wise,
Yeah.
you know, but on myself, it's like, yeah, I'm going
Yeah.
for it. So, but the MAT side of it, I
Yeah.
feel has been a huge part of being able to be where I am and, you know, functioning. I mean, I push it on
Yeah.
my hips and it's great. So
Yeah.
yeah.
That's great. And you said it perfectly there is I mean, there's so many contraindications of what you can and cannot do after a surgery like that. And it's because, well, you don't want to dislocate the hip.
Right.
And we have this idea that it's all the passive structures, the ligaments that are holding the hip in proper alignment, and you have to wait until you're stronger or until everything repairs. But muscles move bones and muscles hold bones in proper alignment. And that idea that if you can get the muscles activated, they have the contractile ability to stabilize joints. And so to avoid movements because they've seen hips dislocate by going into those movements is because there was a lack of neuromuscular control. To get those muscles activated so that you can go into those positions is the ideal situation. Comfortably go in those situations because you have stability, and the body protects you from moving into the positions where it knows it's unstable. And then literally as you provide that stability, and all of a sudden it's like, oh, I can go into adduction, or I can rotate the hip. And but again, you have the medical guidelines that you have to follow and respect on your own client. But
You said a long time ago, muscles are the primary and ligaments are the secondary stabilizers. And that's always been kind of a mantra, because we kind of learned that wasn't necessarily what we learned. And that became really a kind of a mantra. Like I said, it's true.
Yeah. It's so funny. I think you guys remember I did a deal with Cirque du Soleil. Where I trained all their physical therapists from every show across the country. And if there was ever anything that I thought would show a void in the MAT principles, I thought it would be, okay, these people, I mean, they're so hypermobile, and where are you going to find muscle tightness and protective tightness? And I go in and I start working on what they call their artists. They don't call them athletes, they call them artists. And they're hypermobile, and one had shoulder surgery and another had an ACL repair. And I'm going through and they're hypermobile and great ranges of motion, great strength in certain position. Then all of a sudden, like one guy couldn't, with his arm against his body, he had no external rotation in the shoulder joint. And it's like, wow, the principles are the same, but you have to find the detail. Where are their weak links? And it ended up, he couldn't hold anyone over his head anymore because of after the rotator cuff surgery. And we get these muscles activated and he's strong and stable in his overhead motions. And again, but where I was going with that is one of the physical therapists, I'm talking about how ligaments are secondary tension regulators. And she says, no, the ligaments, my artists hang on their ligaments. When they're doing their routines, we don't want muscle control. We want the muscles so relaxed that they can hang on their ligaments. And I'm like, I don't know if that's the right way to think about it, because if you don't have neuromuscular control, where we talk, the ligaments are secondary tension regulators. And when the muscle system fails, the ligaments are they don't have the contractile ability to stabilize joints. And that's when they end up trying to stabilize the joint and they tear. And we've all seen that.
And you're already talking about a population that has a lot of them have hypermobility that's the reason they move so well. So they need that tonality control, that
The muscle control, yeah, through those great extreme ranges of motion, they can't function without it. But you think of that with gymnasts and Cirque du Soleil, how long do their careers last? I mean, 24, 25 years old, because once they have an injury, they start that downward spiral because their sport still requires those extremes of range of motion and control in those extremes of range of motion, but they don't have the muscle control to be able to stabilize themselves through those ranges of motion. And then the one injury can lead to a downward spiral.
In that group has a lot of labral injuries because they're teetering so far off the edge of their architecture, arthrokinematics of the joint. The ligamental laxity doesn't really keep them tight around that slide. So if you don't have the contractile muscle work, then I think that group is really vulnerable.
Right. Yeah. And so I think that's great information, great connecting with you guys again. And I think maybe we'll finish off with the idea is like, as physical therapists, I mean, and looking at people with the potential, not knowing what muscle activation techniques is, I mean, do you have recommendations for physical therapists on why they should look into MAT as an education model and how it can work with what they do versus against what they do?
Oh my gosh, it's absolutely works with what you can do. It is a tool that is, after 30 years, I feel like I've had so much, continuing ed. We're required every year to do continuing ed, 40 hours every 2 years. And so I've seen a lot of the different ways of treating patients, but this by far trumps everything that I've ever learned, because it is working on the neuromuscular control. And it's such a systematic approach. It's not, there's no such thing as just making the assumption that there is an issue. I love to prove, you always said you love to prove yourself wrong. And I always love to ask the question, but why? Why is that happening? And so this is the one modality where you can absolutely test, if you have a theory, you can test it. There's so many control points through the whole system that if you follow the system, you really can't go wrong. And as far as the patients on day one, after being treated, they are all in 100% committed, because they realize that, wow, there is I immediately notice a difference. And so, I think for patients, it's an absolute gift. And I don't know anything else where you can make that immediate change. No other modality that I've used can make that immediate and long-lasting change. So I wish they taught this in PT school. I mean, it is a blessing. And, I just thank you so much, because it's made such a difference in my life in treating patients. And I can't tell you how many patients I've had, over the years that have been so thankful for the MAT process. So I wish every PT went through.
Oh, that was really good. I would just add to that I think the dwindling dollar in the physical therapy arena is another. If I can see a patient a few times, like if you have somebody that has surgery or an issue, you're not getting the 60 visits anymore that you used to get with insurance companies, and they're way more stringent on what they're allowing. So if I can have such a powerful impact on a few visits, and I can show them why to buy into the process, I'm getting a lot of patients now that want to do the exercises because they see the results. I get much more compliance with MAT because they go, whoa, man, this guy, it didn't feel so good when he worked on me, but it worked and it held. And then they're buying into the exercise program. And I don't have that problem where it's like I hand them a sheet and then they call me later, man, I just didn't get the exercise, because they saw the results. So compliancy and the dwindling dollar, you can see a patient for less and get positive results. Also, if you ever think of becoming a physical therapist and having a niche, and then you go for the cash only, because that's also changing. I don't know what's going to happen, but for the last year, I practiced as a PT with just cash only, and I was busy. Okay. And because I do MAT. Now, I don't know if that would have happened if I did cranial sacral. I'm sure, you know, there's a lot of people doing other things and they have their niche. But for me, having an MAT PT, I was busy all the time and it worked out great. So it's just, it's been awesome. And thank you. It's been an awesome ride. Yeah. And I'm always, you know, you're like a moving target because your brain never, you know, I don't even know if you sleep, but coming up with new ideas and talking to you about, well, what's next? And we've kind of went, wow, okay, it moves, but every time we go with it, it's like it's better. So keep after it. And when we're 95 and we're in diapers, we'll still be in your class, I guess.
Yeah. And that's a great thing.
Okay, I'll be in some.
Yeah, the great thing is it does still, I mean, continue to evolve. You know, the nervous system's so complex, the neuromuscular system, and the body's so complex that it never is going to end. And but I think the summary, that systematic process that we have is what makes it. I mean, it takes out the guesswork, and that's what makes it. When you have a process you can go, I say many times, I don't care what you can do, I want to know what you can't do, because what you can't do is going to break you down. And how do you know what they can and cannot do if you don't have the ability to assess and test it? And that's the process, the evaluation process of MAT. If you're evaluating it when you put forces on their bodies, like you said, the foam roll, the stretching or whatever, does it have a positive or a negative effect? Or if they're doing exercise, I mean, some exercises could be good, and the contraindicated exercises are more contraindicated because of their individual biomechanics and their neuromuscular integrity, not because the exercise was actually a bad exercise. But how do you know? And like you said, with the hip replacement, they say don't move into these positions because it's been shown to be contraindicated, because you can see hips dislocate if you go in there without stability. But when you have muscle control, then you don't have the vulnerability. But how do you know you have the muscle control? And that's what MAT brings to the table, is the ability to attest, to determine what you can do, which is great, but what you can't do is what leads to the dysfunction and that downward spiral that you were talking about with that, say, that ACL client.
Yeah.
So it's a neat thing to follow, you know. I mean, it's been neat to have you guys involved again since the beginning and before the beginning of MAT, but back in Bellingham and having that first conference when I was still figuring it out, but I knew there was something there. And nice to see from my perspective of being a muscle specialist with the background in exercise science, and not supposed to be in the pain world, but if you don't have proper muscle control, you're dealing with chronic pain and acute injuries. And so to tie it all together for the field that I came from, but then to see that, man, this fits in all, I mean, there's a place for it in physical therapy and other modalities. And to know that I wasn't even thinking that when I started. I was trying to isolate my own world.
That's fine. No, just a last piece too is as people are living longer, and the geriatric population, you know, that needs to happen for the group that on Medicare. There's a huge group of people that want to be active later in their life, and I think there's a big void there for muscular stability, and that's another whole area. And so, because sky's the limit.
Yeah, exactly. Well, great to have you guys involved and part of the process, and thank you for taking the time today for this interview.
Well, thanks.